Good afternoon, everyone, and welcome. This is Dottie LeBron with the McSilver Institute, along with the Community Technical Assistance Center and Managed Care Technical Assistance Center. And I'd like to welcome you to today's webinar, Housing is Healthcare. What can be done to address the most important social determinant of health? The McSilver Institute, CTAC, and MCTAC have partnered to launch this multi-platform online series intended to help clinical professionals, community health workers, educators, policymakers, and any and all who influence our healthcare system. We're aiming to help stimulate a dialogue to critically think about those social factors that have a direct and indirect impact on an individual's health and mental health. Throughout the series, we'll bring into focus the linkage between poverty, racial disparities, and health inequities, and discuss ways in which these issues can be addressed to improve health outcomes for all. So just a few housekeeping items before we get started. I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining webinar, you've been placed on mute to avoid any background noises that may distract others from listening to the presentation. And if you come across any technical issues during today's event, please chat to the host and she'll be able to assist you. You're going to have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. And if it's not visible, click the dialog bubble on the top right toolbar and it should appear. In order to ensure that we're able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, and we'll address them during the Q&A portion of today's webinar. Okay, and so with that, we are very excited to have Ted Houghton with us today to talk with us about the critical significance of housing stability in determining the health and well-being of individuals and families, particularly those experiencing disabilities. Ted is the president of Gateway Housing. Prior to Gateway, Ted served as Executive Deputy Commissioner of New York State Homes and Community Renewal, overseeing the state's Housing and Community Renewal Corporation, Affordable Housing Corporation, Division of Housing and Community Renewal, and the State of New York Mortgage Agency. Previously, Mr. Houghton led the Supportive Housing Network of New York, a member organization with over 200 nonprofit supportive housing providers and developers that operate more than 50,000 supportive housing apartments across the state. Ted has also been a writer and a policy advisor to government, foundations, and nonprofit organizations on housing, mental health, employment, and homelessness, and he has worked for the New York City Department of Homeless Services and the Coalition for the Homeless. So as you can see, Mr. Houghton, Ted Houghton, has so much to offer us in this conversation, and we are so pleased to welcome you. Ted?
All right. Well, thank you, Dottie. I appreciate McSilver Institute and MCTAC and CTAC for drawing attention to the importance of social determinants of health, because the more that you delve into this, the more you realize just how important they are to people's everyday quality of life, and how so often they're overlooked. And so this series is really important. The previous webinars, they address critical factors that have substantial impacts on health, like employment, racism, sexism, trauma, incarceration, you name it. I call housing the most important social determinant, not to devalue these other important causes, but because stable housing is so often a prerequisite for achieving good health and addressing other social determinants, particularly in New York City and other high-cost areas. I'd like to start today's webinar by taking a step back and asking a very basic question. and that is, what is it that we want? Do we want better health care or better health? It's important to know what business you're in. You could just ask Kodak. In 2012, Doctors David Ash and Kevin Volk published a perceptive article in the New England Journal of Medicine entitled, "What Business Are We In?" And they called it the emergence of health as the business of healthcare. In the article, they talked about the Eastman Kodak company, which had just gone into bankruptcy after 131 years of dominating its business. They talked about how Kodak thought it was in the business of selling cameras and film, but discovered too late that it was in the business of selling images. When computers and phones changed the way people viewed, stored, and printed images, Kodak's cameras and film became worthless, and they went bankrupt. The two doctors held up Kodak as a cautionary tale for hospitals and medical providers that focused on health care over health. But I think their message is especially relevant to government, because rather than promoting, I'm having trouble getting my, there it is. Rather than promoting good health, American government is very much in the health care business. Medicaid and Medicare cover 1 out of 3 Americans. That's over 100 million people. Together, the two programs cost over $1 trillion a year, almost all of it going toward medical interventions. In New York State, Medicaid is the single largest item in the state budget. It's fully 1/3 of all spending. Now, 45% of that is paid for by the federal government, but it is the largest item in the New York State budget. Spending so much on health care does not guarantee better health. It doesn't even guarantee better health care, really. Medical care accounts for just 10% of overall health. Social, environmental, and behavioral factors determine the rest. That's why we're all talking about the importance of the social determinants of health. Unfortunately, we have a long way to go. Of all the countries that belong to the Organization for Economic Cooperation and Development, that's basically the first world, the advanced democracies, the U.S. is first in healthcare spending, but 25th in spending on social services. And those are really related. We're not spending on the preventative measures and the measures that give people healthy quality of life, and so we end up spending so much on medical care. If social determinants are 10 times more important to health than medical care, I mean, we got to ask, shouldn't we be spending more to address them? And I think you would guess that the answer is yeah, but we don't. And as a result, the United States is largely in the bottom third of the OECD countries in most health indicators, except for obesity, which we're #1. To be fair, many social determinants are complex and deeply rooted in our culture. While we've made some real inroads in devising effective ways to address trauma, we can certainly counter racism, sexism, and stigma. It's not easy. So it's not surprising if our first response is to just prescribe some medicine or wait until you get sick enough and then put you in a hospital. Addressing social determinants is hard work. But housing is a social determinant that's simple. If you have a roof over your head and a decent place to sleep, you're going to be healthier. It's not rocket science. If you have a place to live, you'll be safer, you'll be happier, you'll be less stressed out, you'll be more likely to eat right, take your medicine, you'll be less likely to engage in risky or destructive behaviors. It's simple, it's simple. It's if you are housed, you will be healthier. This is especially true for people with special needs. And why is this important? Well, if you ask government, it comes down to one thing, and it always does, and that's money, enormous amounts of money. I personally believe that poor people with disabilities and other barriers to independent living should be allowed to live in housing. If that requires a publicly funded subsidy, so be it, whatever. I know. You know, it's a crazy idea, and the majority of elected officials disagree with me, and they're confident that their constituents disagree as well. So we have to come up with reasons other than basic human decency to convince them to house people with mental illness and other disabilities. And we have to prove to them that these individuals can live in housing, and we have to put a lot of pressure on them to make sure they actually do it. I'm going to tell one story of how some people persuaded one state to fund housing for sick people so they wouldn't be so sick anymore, and why they were successful. It's not a unique story, but it's not as common as it should be either. Telling it may convince others to invest more resources in what is a pretty obvious and simple solution. It has 4 main ingredients for success. That's fiscal pressure, a ready solution, compelling research, and effective advocacy. Back to the money. New York State spends $53.9 billion a year on Medicaid. Earlier I said $54 billion, but that meant I was rounding up $100 million, and it's just not right to round up $100 million. That small rounding error in the Medicaid budget could fully subsidize decent apartments for 7,000 people a year. That's how big Medicaid spending is. New York spends more on Medicaid than any other state, even California, which serves more than twice as many people in its Medicaid program. That's because New York's per capita costs are some of the highest of any state, and these costs are growing, although more slowly than they previously were, thanks to Governor Cuomo. One reason New York's Medicaid costs are so high is because we have so many hospitals here, and we're so quick to use them. The good news is that Medicaid costs are concentrated on a relatively small subset of recipients. Just 18% of the New York State Medicaid population uses 56% of the resources. That's right. That's 18% of the population uses more than half the resources. Some of these high-cost users will continue to use a disproportionate share of resources. That's end-of-life care, premature births. These things are expensive and they will remain so. But many high-cost Medicaid recipients cost so much because they rely too much on the most expensive interventions. They go to the emergency room for primary care. They cycle in and out of detox center. When they're hospitalized, they stay longer than they have to. Basically, they're homeless or unstably housed. They're exactly the individuals who would benefit from supportive housing. 51 to 58% of special needs populations in New York State are high-cost Medicaid users. With over half of New York State's Medicaid dollars being spent on less than 20% of the recipients, the state had more than enough motive to do something. Fortunately, they also had a readily implementable solution, and that's supportive housing. At the time it was created, back in 1980, supportive housing was an untested, daring model, really. It was created not in response to public funding streams or policy decisions, but by mission-driven pioneers who saw a problem and decided to try to solve it. It was a pragmatic solution. It had 2 innovations. It basically replaced the institutional care that everybody thought people with mental illness needed. Everybody needs to be locked up in psychiatric centers. It replaced that with a person-centered community mental health approach. And it improved on the SROs and flop houses that people were living in. So there was this whole perception that people needed to be institutionalized, but the fact was, after the invention of Thorazine in the 50s, many of them, tens of thousands, moved to New York City and lived in flop houses on the Bowery or SROs on the Upper West Side, and were doing just fine. You know, not great, but they were living in the community. This new solution of supportive housing took over many of those SROs and created a decent physical environment with a more constructive tenant-landlord relationship. It offered permanent housing, it offered efficiency apartments, and on-site voluntary services. It offered a person-centered team approach. So we had this problem, too much spending on Medicaid, and we had a solution. Now we just had to convince the decision makers that the 2 were connected. We didn't have much political muscle. All we had was good policy arguments, but we had plenty of these. Shirley and Cooper of the New York City AIDS Housing Network, which is now known as Vocal, great advocates, once said, advocacy without research is just a temper tantrum. That is so true. We tried to come up with some arguments. First, it was supportive housing is the right thing to do. Then we tried to come up with some arguments about cost reductions. Hospitalizations cost $2,000 a day. I mean, these are this year's numbers. They were a little bit less before, but more or less the same. Nursing homes, $217 a day. Supportive housing, just $70 a day. This was our first attempt at showing the cost effectiveness of supportive housing, and it got people's attention and grabbed headlines. But when you got into government and talked to the budget people, they said, yeah, but how do I know that I'll stop spending money on hospitals and nursing homes when I start spending it on supportive housing? To prove that, we really needed real research. And that brings us to the third element of this, compelling research. There's been dozens of studies over the past 15 years that have documented service use reductions and cost savings when vulnerable people move into supportive housing. The largest of these cost savings are associated with healthcare and medically vulnerable populations. The first study was the New York Agreement Cost Study. That was back in 2001. It's often called the Culhane Report after Dennis Culhane, the University of Pennsylvania researcher who did it. Dennis took a look at almost 5,000 homeless single adults with mental illness who had moved into New York, supportive housing and licensed housing built by the New York Agreement, the first one in 1990. Built almost a little more than 3,300 units of supportive and licensed housing in the 1990s. And he took a look at almost 5,000 people with mental illness who moved into this house. And he found that before they moved into the housing, the average homeless mentally ill person in New York City used about $40,000 of publicly funded services every year. Just to keep homeless, we were paying $40,000 a year. That's on shelters, emergency rooms, psychiatric hospitalizations, you name it. He took a look at the service use of those very same individuals the year after they moved into service-enriched housing, like supportive housing or community residences. And he found that each individual reduced their service use by about $12,000 a year. The reduction in the service use paid for 95% of the cost of building the housing, operating the housing, and providing services in the housing. These are all $1999, but very relevant to today. It's even more now. The study identified exactly where the cost savings came from. Most of the service reduction savings resulted from a 33% decrease in the use of medical and mental health services. New York residents cut state psychiatric center use in half for every housing unit constructed. Their use of publicly funded acute hospitals, basically Health and Hospitals Corporation hospitals, Bellevue and others, for both psychiatric and medical treatment dropped from 8.25 days a year to just 1.65 days per year per person. It's a huge drop in hospitalization because they had a place to stay. And when they actually did go into the hospital, they got out very quickly because they could go home. The use of their outpatient Medicaid really went up. It doubled. And that was because people were taking care of long deferred physical ailments they were getting treatment for substance abuse and mental health. But even as that outpatient Medicaid doubled in cost, it was far outweighed by the savings in inpatient Medicaid spending. It really had huge savings. These kinds of findings were replicated over and over again over the last 15, 16 years. I'm going to talk about a couple other studies that have happened that are noteworthy because they focus on medically frail populations, but there are over 40 of these that I can think of, and more coming every day. They're quite compelling and very consistent findings. The Home and Healthy for Good is a good one. That's on the Massachusetts Housing and Shelter Alliance, and it was the study was published in 2012. Home and Healthy for Good program provides supportive housing to 555 chronically homeless adults in Massachusetts. Those are people that have been homeless for more than a year and have some kind of disability. The residents experienced a dramatic decline in service use and associated public expenses. Their annual Medicaid-related expenses were $26,000 per tenant before housing and $8,500 after they were placed into the housing. When you factor in all the housing and services costs, the Home and Healthy for Good program saves the state $9,423 per person per year. For example, the average tenant spent 5.16 days in a detox center in the year before they were housed and only 1.48 days a year the year after they were housed. That's a 71% drop in the use of detox. It's quite significant when you have some medical procedure that's as expensive as medical detox. Another good study is out in Portland, looking at residents of the Bud Clark Commons, a supportive housing residence in Portland, Oregon. Tenants on Medicaid at Bud Clark Commons averaged roughly $2,000 per month in healthcare costs in the year before they moved into the housing. Once housed, that figure dropped to just $899 a month. That's a 55% decrease. Collectively, 59 tenants at BCC reduced their Medicaid costs by $783,000 in just 1 year. That exceeds the annual cost of the housing for these tenants. The annual savings increase, you can see in year 3, it's down to $680 per tenant a year. It's really, really significant. The cost savings that we're seeing are most substantial for the really medically frail populations. There are 2 good studies looking at these, and these ones took the next step in research. The Chicago Housing for Health Partnership in 2009 looked at 407 chronically ill homeless people, including about 1/3 who were HIV positive. Half got supportive housing and half got usual care. The Housing and Health Study looked at people in Chicago, Baltimore, and Los Angeles. These were 630 people who were HIV positive. A quarter of them were homeless, most were doubled up, some were at risk of homelessness. All of them received case management, help finding housing, referral to medical care, behavioral prevention interventions, but half were given housing vouchers. Housing for opportunities for people with AIDS, and these allowed them to really get into the housing market. The significant thing about these 2 studies is that instead of doing a pre-post analysis, you know, how you did before you moved into the housing and how you did after the housing, which was compelling, these ones actually had a control group that didn't get housing that you could compare people to, and you could see that you could eliminate any other factors that might have helped create the decrease in healthcare costs. And even with that more rigorous program model, they had really good results here. At the CHHAP study, the housed participants were 3 times more likely to be stably housed at 18 months. They had significantly fewer hospitalizations, fewer hospital stays, fewer emergency department visits than their usual care counterparts. They reduced the nursing home days in half. The 200 participants in the program that got housing saved almost $1 million a year after the housing costs were taken away. From the not housing taken away from them, but the housing costs subtracted from the total cost. The Health and Housing Study, or Housing and Healthcare Study, looked at people living with HIV, and half of them got AIDS. Half of them got vouchers from the Housing Opportunity for People with AIDS program at HUD. Spoiler alert, they increased their stability and improved their health. At 18 months, 85% of the voucher recipients remained stably housed, while 15% were unstably housed. But in the control group, 44% were unstably housed. Compared to housed participants, those who experienced homelessness during follow-up were 2.5 times as likely to use an emergency room and 2.8 times as likely to have a detectable viral load. They had more stress, and they were more likely to report unprotected sex with a negative or unknown status partner. So that's really significant because this basically says that housing is not only health care, but housing is health care prevention. If you can prevent another HIV-positive infection, you're going to save about $300,000 at minimum over the lifetime of that person. So housing becomes not just a prerequisite for improving people's health care and health status, but it also prevents them, reduces their likelihood to infect others, and that saves enormous amounts of money. Links to all these studies can be found at the website of the Supportive Housing Network in New York. I've got the link right here. Cynthia Stewart there has done a great job of assembling all of these studies. There's, like I said, there's more than 40 of them on cost savings alone. Please go to the website. I think it's really worth taking a little bit of time there to look at those. The last part of this story is effective advocacy. So we had the problem, we had the solution, and we had the research to support it. But we really had to go out and pound the pavement to convince people, and we needed an opportunity to do so. And that opportunity came in 2011. When Governor Cuomo came into New York State, became governor, he faced a real fiscal crisis, and he knew immediately that if he was going to do anything about it, he really had to address the Medicaid budget. And we were very fortunate to get Jason Helgerson in as the state Medicaid director from Wisconsin. And Governor Cuomo in 2011 announced what he called the New York State Medicaid Redesign Team, the MRT. And that provided an advocacy opportunity for the housing as healthcare kind of argument. The MRT process assembled a wide range of stakeholders in the healthcare community. So they had hospitals, they had doctors, they had healthcare advocates, patient advocates, they had long-term care participants, they had legislators, all sorts of people, everybody but housing providers or housing advocates. They held lots of meetings, and they had hearings, public hearings all over the state to look at potential cost efficiencies. Basically, you could go to one of these hearings and you got 2 minutes to give them a good idea of how they might save money in the Medicaid budget. It was actually quite a good process. After a few meetings, the MRT committee made an agreement. They agreed to try 96 new cost containment strategies, and they agreed to a global spending cap on state Medicaid spending growth. Basically, they said, if we don't make this cap, and it was, I can't remember if it was about 3%, 4% a year instead of 13% a year, if we keep the level of growth down at that low thing, we can use the savings on innovative strategies. If we don't, the Department of Health Commissioner has superpowers to impose an across-the-board 2% cut to all Medicaid. Nobody wanted that. And this is really, really something, because most governors, when they cut Medicaid, they basically make some people ineligible, or they make some services unavailable. In this case, Governor Cuomo said, let's try some innovative strategies and see if they work before we start doing across-the-board cuts. And sure enough, they worked. One of those strategies was supportive housing. And the way we did that was with consistent advocacy message. We did housing, housing, housing. Everywhere that the MRT went, every public hearing, there were people lining up to tell them how supportive housing had improved their health and how supportive housing had saved them money. It wasn't just providers of supportive housing, but it was tenants. And it wasn't just tenants, but it was also healthcare providers in those localities saying, this really helped. And by the end of it, the MRT stakeholders on that committee were convinced. Most of them had never even heard of supportive housing, but by the end of it, we had even the head of the Greater New York Hospitals Association, which is, he is the medical establishment, was saying what we need is more supportive housing. And I don't know if he even knew about supportive housing before he started going on these listening tours, but he was a great advocate for it. And one of the reasons was because we kept on referencing the research. As a result of that, an affordable housing work group subcommittee was formed, and that had a lot of housing providers and housing advocates, and we made the most of the opportunity to come up with a plan. What the MRT was able to do was to take state share cost savings in the Medicaid budget, anticipated cost savings, and the fact is that the Department of Health kept making its goals, so there kept on being money available, and we reinvested this in housing. In the first year, the MRT invested $75 million into supportive housing, and they did it by taking, this is just the state's share, so the state had control of it. You know, state pays 55% of Medicaid. So they put $46 million of that into capital funding to build new units, to build 471 new units in the first year. It was combined with other kinds of housing money. Paid $19 million for rent subsidies and service subsidies for people in supportive housing. And then we used $9 million for other kinds of innovative programs. This number kept growing. By the last year, I think it was $121 million that was being spent on supportive housing. And this was coming out of the Medicaid budget, going into housing to provide that housing to people who are high-cost users. And this was really something, because before, budget directors would say, I love that supportive housing saves money, but how can I capture those savings? I mean, you say that it results in fewer emergency room visits, but I'm still keeping the emergency room open and I'm still spending that money. In this case, we are saying, no, this is happening right here in the Medicaid budget. You are spending less on Medicaid because people are in supportive housing. Therefore, let's take those savings and invest it in more supportive housing so we can see even more savings. In the first year, we got $75 million. Since 2012, the state has appropriated $388 million in Medicaid savings to build, operate, and provide services in supportive housing. We've created more than 800 new supportive units, provided more than 1,200 rent subsidies. We've funded services for more than 2,000 units. It's really been something. But a lot of that has been subsumed into other kinds of efforts that the state is doing. The governor has made an advocacy effort of ending AIDS in New York State. Part of that effort is to provide housing for people. As we see, it cuts down on retransmission, it cuts down on viral loads. It really makes sense. So some of that money is now going towards that. Some of that money is being combined with the $2 billion that the governor appropriated last year for affordable housing development. And the MRT continues to look at what happened over these last 5 years and see which supportive housing strategies got it the most bang for the buck. So I think we can see, as long as those numbers continue to look good, and they do, and they show savings, the state will remain committed to building supportive housing. The governor committed to building 20,000 units of supportive housing over the next 15 years. That's the biggest commitment ever. So we all agree, housing is healthcare, but we need to get it to scale. How do we do that? Many believe that the well-documented link between housing and health would result in Medicaid reimbursing supportive housing costs. Some thought that the Centers for Medicaid and Medicare Services might be convinced to pay for everything, just like the state did, for capital, for services, rent, everything. The state tried to get that to happen. Others were more sanguine, and they advised advocates to concentrate on CMS, getting them to allow Medicaid to pay for housing-based services in supportive housing through something that's called the 1915I State Plan Amendment Option. The Affordable Care Act in 2010 updated the 1915I. National advocates led by the Corporation for Supportive Housing did a very good job at making this regulation user-friendly for supportive housing services. So, yes, those federal funds for services would be welcome, but CMS made clear that they were not in the housing business, that Medicaid didn't pay the rent, so that was what we're going to have to work with. On the other hand, you know, we were wondering what happens when you start funding something that has always been through state and city contracts that we have gotten used to. What happens when you start funding that with Medicaid? I mean, that's a whole different world of reimbursement. I'm a skeptic, I'm something of a worrier, so at the time I questioned whether this would be a good thing to put Medicaid into supportive housing, particularly for states that already had a lot of supportive housing. Back in 2012, I made a presentation and used this slide, all unicorns and rainbows, and that's the dream. Medicaid could be the most wonderful thing. You know, entitlement funding would bring us to scale. I mean, Medicaid is so much more money than we spend on housing now. The focus on high-cost recipients would target those most in need. Managed care strategies would direct funds to most effective programs and providers. And the result, you know, you would have the equivalent of a right to housing for high-cost Medicaid recipients, because why wouldn't you spend Medicaid funds on housing if that got you much lower Medicaid costs? There was also the nightmare, and we let our fears run wild, and maybe that wouldn't be fair, but, you know, the nightmare was that Medicaid would destroy supportive housing, and that it would impose a medical service model on supportive housing's whatever it takes approach. I mean, this is really meeting the client where they're at, and if it meant like going shopping with them and taking them to the doctor's appointment, those were important things that really made a difference, but they might not be funded by Medicaid. And you might find that experienced community-based supportive housing providers, who could be sometimes a little more grassroots, would be more crowded out by traditional Medicaid providers. And the fact is, nursing homes don't give us these kinds of savings. The people that are used to billing Medicaid don't achieve these savings that supportive housing does. And if they got into the supportive housing business, would we still see those savings? We're also worried that managed care organizations that were doing managed care Medicaid, they could impose time limits on people for the housing. They could exert downward pressure on the service funding level, say, hey, this person's doing well, why do they need that level of service? And so, you know, I was nervous about what might happen. The fact is, change is slow. Neither our highest hopes nor our greatest fears were ever realized. You know, things just don't move that quickly. And the world didn't change as much as we feared, or neither as much as we hoped. Back then, we had a lot of concerns about integration of Medicaid into supportive housing. It seems almost quaint now, given our current situation in the politics. I mean, we were worried about how they would, supportive housing would relate to health homes care coordination, which is still an ongoing challenge. How do we remain responsive to the way people's needs fluctuate over time? How do we make sure that supportive housing remains a permanent housing model? And, you know, how do we, you know, just make sure that the model remains, you know, vibrant? And, you know, how do we work with HUD homeless definitions and high-cost Medicaid recipients? You know, there's all sorts of different ways that we could worry, but you know, Olmstead integration, you know, you name it. But like I said, it seems almost quaint now when given our current political situation. I think that for the most part, Corporation for Supportive Housing, CSH, and others, they worked with HUD to get it right. HUD did really, you know, was very responsive in trying to preserve the effectiveness of the model. In advising CMS on how to do 1959. But the fact is that even so, you know, the federal government has resisted using Medicaid to pay for housing. New York State applied to the federal government for what's called an 1115 waiver for $10 billion. They basically said, we're going to save $17 billion in Medicaid over the next 5 years. We would like some of that money back, because some of that's going just to the federal government. We'd like $10 billion of that back for innovative programs that we can do that will further reduce Medicaid. And one of those was $525 million over 5 years for supportive housing. That's Medicaid money from the federal government. Prior to this, the state was only using state share savings for MRT. So they asked for an equivalent amount from the feds. In 2014, CMS approved the waiver, but they didn't give any funding for housing. They provided more money for prevention, more money for hospitals that were doing innovative things that would lower costs, but no money for housing. They drew the line at housing. And CMS has consistently refused to allow federal Medicaid funds to be used for housing. Also, states have been slow to harness Medicaid funding now available for services. Even as the 2010 Affordable Care Act expanded 1959 home and community-based services waiver to pay for flexible services for broader populations in supportive housing, the states that already have a lot of supportive housing have not jumped to that. It allows Medicaid to pay for most services in supportive housing. But, and that's really important for a state like Kentucky or something that doesn't spend a lot of its own local dollars on supportive housing. But for the state, you know, as much as they've looked at it, they've been slow to really jump at it. They've not rushed there. They're worried about, well, would residents' eligibility as, medical necessity is a baseline for any Medicaid payment. Would the medical necessity of supportive housing be doubted by auditors? That would be a concern. Which services are covered, under what circumstances, who delivers it? These are very important questions, and you don't know. You could have a clawback of your Medicaid payments 6 years after you were paid, and you've long spent the money. You could worry about double billing. If the clinic down the street is providing rehab services and you're providing rehab services in the housing, would somebody come along and say, hey, wait a minute, that's double billing? Just administering Medicaid is a specialty. Not all housing providers have that ability. So generally in states, in New York State and places that have extensive supportive housing, as long as the traditional funding sources remained available, the attitude was largely why disrupt them. Another thing that I thought would happen that didn't happen is Medicaid managed care programs. They've been cautious about investing in housing, even as they see that it's important to health. I mean, every insurance company understands now that, getting people into housing, getting homeless people into housing is the first thing you need to do in order to reduce their high Medicaid costs. But why would they pay for something that government already funds? That's what HUD is for. So they see that, they're beginning to contract with behavioral health providers for risk assessment, care management, even housing navigation to help you get into housing. But they've held the line at paying for that housing for the most part. And because of that, we haven't seen a big expansion in supportive housing on the levels that we thought might be possible with Medicaid. That might still happen, but so far, not quite. So we have a lot of promising programs. The good news is there's too many for me to list. I mean, the 100,000 Homes campaign run by Community Solution is now in 186 communities. They've worked with all sorts of programs to get 105,000 people placed into housing, and these are targeting the people with the highest healthcare needs, chronically homeless people, the ones that are the highest cost users, getting them into housing. And that's really important. That's changed the culture in a lot of localities. The Housing and Urban Health FQHC in San Francisco coordinates care with supportive housing residents. This clinic bills Medicaid and provides services to all sorts of people, medically frail and mentally ill people in the Tenderloin in San Francisco, and they live in supportive housing, but they're getting a lot of the services they used to get in supportive housing, they're now getting at the clinic. And the geography of the area, the clinic is very close nearby, and it allows for that. And this is a shift of services going to Medicaid. They're being provided in different ways by different people than the traditional supportive housing model, associated with the clinic, but it's really been very successful. Hennepin Health in Minneapolis funds housing navigators to facilitate housing placement. The Department of Health Services in Los Angeles pays nonprofit partners for case management and housing-related services linked to supportive housing. I mean, there's things going on in Portland, Columbus, Seattle, Philadelphia, everywhere. I mean, let 1,000 flowers bloom. It's really, we have an awful lot of success to build on. Nevertheless, housing remains the greatest unmet need for an enormous number of people with chronic illness. I'm going to borrow this from Nancy Bernstein at the National AIDS Housing Coalition and a number of AIDS advocates. I mean, 1.2 million people living with HIV or AIDS in the United States. Half of them are going to need housing assistance at some point, 600,000. But HOPWA, the main voucher program, only serves 70,000, so about 12% of them. We just don't have enough housing vouchers for them. There's not a single county in the United States where you can afford a studio if you're on SSI. We need this help, but we're just not going to scale. And we can't build the housing fast enough. Here in New York City, we have roughly, we have officially 13,000 homeless people in the single adult system, but there are many ancillary systems like the Safe Havens and Youth and HASA and a number of places. And then we have 3,000 homeless people on the streets on any given night. So we have around roughly 15 to 20,000 homeless single adults every night. Thousands more in substandard housing like three-quarter houses and institutional care like adult homes. And then we have some percentage of homeless families that are going to need supportive services. We're trying to build supportive housing for them, and we have the largest supportive housing production goals that we've had in a long time. Mayor de Blasio committed to 15,000 units over 15 years. 500 new units, capital units being built each year for 15 years. The state did 20,000, the governor said, over 15 years. That's 1,300 new supportive housing units being built each year for 15 years. But there's uncertainty about continuing federal resources, the low-income housing tax credit that's used to fund most of these, tax-exempt bonds, McKinney-Vento funding. We don't know what's going to happen. And there's still not, even if those things stay at the same levels, there's just not going to be enough housing to meet, to house 20,000 homeless people that we have now, even over the next 10 years, even as we're doing all this additional work. So I'd like to just take a step back and say, let's look at it a slightly different way. If housing was a pill, we wouldn't be having this conversation. In the healthcare world, they have a different metric. We've been talking about cost savings and saying, hey, look, we save $10,000 for every housing unit we build, and that is really compelling. But, that's a pretty high bar. In the medical profession, they say cost per quality adjusted life years saved. That's the metric they use to measure the bang for the buck of each medical treatment. If you look at HIV risk reduction and treatment intervention, preliminary findings show that housing is a cost-effective healthcare intervention. It's got a quality adjusted life years saved rating of $16,000. That's lower than most other interventions that doctors prescribe to people living with HIV/AIDS without even thinking twice, because that's what they need. So if you look at the chart here, this is Nancy Bernstein put this together. Lovastatin, warfarin, all these things that, you would get a prescription for if you needed it because you had coronary disease or you needed some kind of screening. They would give this to you without even blinking, and it costs so much more money than supportive housing. But they can't prescribe supportive housing because supportive housing is not a pill, and it's seen as something that's not Medicaid eligible because it isn't, except for some services. And we have a long way to go because really, this is the most cost-effective way that we can help people live healthy lives. I'm going to pivot now, and I want to talk about not just special needs populations, but affordable housing and low-income tenants writ large, because, even if we were to build just for special needs, we would still need to, because Olmstead, the Olmstead decision by the Supreme Court says that we need to place people with disabilities in the least segregated settings possible. That means putting people into affordable housing with other non-disabled people. And the fact is we need to build affordable housing for families. We need to build affordable housing for all sorts of people. that affordable housing development is an opportunity. It provides a great platform for creating healthy communities. You can build grocery stores downstairs and other amenities and food deserts. You can put health clinics, senior centers, and other community-based services. You can use green construction methods and materials. I mean, just about every affordable housing program and every affordable housing developer is now committed to environmentally sensitive materials. You can put in building services and supports that help people live healthier lives. I'm going to just look really briefly at a few efforts that are being done by both private and nonprofit housing developers. This is a slide from my friend Lisa Gomez at L&M Partners, which is a private for-profit housing developer that does a lot of affordable housing. They went into New Orleans after Katrina and helped them start rebuilding housing, hundreds and hundreds of units. They took a look at this map. This is life expectancy in New Orleans. If you look at the red section here, that's the inner city of New Orleans. The life expectancy is fully 20 years per person less than it is in the suburbs out here in the blue. You know, that is some real health disparities, and it goes across every kind of health indicator: obesity, diabetes, heart disease. I mean, poor people have a much higher incidence, and part of that is because of their environment. And so here, when you're rebuilding all this housing, you need to also address all those community things as well. And L&M, a for-profit developer, chose to do this, and they are committed to do this. As part of their development, they took an old abandoned grocery store and created what they call a community health hub. Let me just show you. This is what it looked like. This is what it looks like now, that it's been turned into a Whole Foods. And it's not just Whole Foods. They partnered with all sorts of nonprofits to help people learn how to cook, culinary, nutrition education, lifestyle, healthy lifestyles programming. It's a community health hub with wraparound services for the community to promote health. And it's being tested by Tulane University. And it really, I think, is going to make a huge difference for this community, and hopefully will also have an effect on their overall health indicators. And that's exactly what we need, and affordable housing development is the platform that's being used to achieve that. Here's another slide from Lisa and L&M talking about the materials they use in their buildings. They really are committed, and like I say, just about every for-profit and nonprofit affordable housing developer is doing this, partly because they're being incentivized by government to use, you know, formaldehyde-free composite board and mold-resistant drywall, you know, things that reduce pollution, putting places to park your bicycle. I mean, and this is become typical. This is the norm now, and that's really important for the overall health of the community. Here's a building that L&M is building on the Lower East Side. It's senior housing, 100 units of senior housing, but they're not just doing senior housing. They're downstairs, they're going to have a senior services center, and they're going to have 35,000 square feet for a medical facility, because that's what the community needs. And these kinds of things, when you think in this comprehensive way, you can really turn the tide for a community, because that's going to be open not just to the building, but to the whole neighborhood. Another thing I'd like to look at is a nonprofit, Breaking Ground, formerly known as Common Ground Community. Breaking Ground has really led the way in thinking about a lot of these things. In their elder care health outreach pilot that they did with CUCS, Janie and Care, they have an initiative that facilitates healthy aging in place. They found that in their supportive housing, most of the people living there were growing old, and the average age was going up, and people were having more and more difficulty aging in place. They weren't as connected to primary care as they should be, and so Breaking Ground brought primary care into the building. They have in-house, easy-to-access health services that really take into account that, you know, the way that seniors want to consume health care in a way that makes them more willing to show up to their appointments and to sit for evaluations and to take medication that's prescribed to them. They coordinate the medical and the mental health care. They coordinate it with the case management and tenant services that are in the building. They have health management and nutrition counseling available to everybody, health promotion and recreation activities. It's really quite comprehensive, and they were able to do this pilot in a number of their buildings, and that's now, it started with foundation money, but it's continuing with Jamie and taking over it, and it's really had some great results. This is in-house difference that they're doing. ECHO now has these outcomes. They're basically cutting things in half. Emergency room visits. A year prior to enrollment, they had 16 emergency visits in the cohort of people that were that they were serving. I think it was around 60 people. 1 year afterwards, they had just 6 emergency visits. The year after that, just 4. So more than half of a drop. Hospital visits, cut more in half, from 17 visits a year to 8. The total days in the emergency room in the hospital went from 109 in the year prior to going into ECHO to 33 and 31 2 years later. So cut it by 2/3 the number of hospital days. And at $2,200 a day, that's huge savings, and this is for seniors. So there's all sorts of things you can do that go around with care coordination that that we're just discovering now, and just about anybody could do this. You know, it just takes a commitment to it. So what's next? Nobody knows. It's probably not good. When I took this assignment from NYU, when I agreed, it was before the election. We had very different assumptions that we were just going to continue to maintain the course on the Affordable Care Act and Medicaid expansion. Now all those things are in doubt. Hopefully success begets success, and the data will win out, and you know, it's very hard to argue against cost savings. But I have seen conservative state governments cut hundreds of thousands of homeless people off of Medicaid without blinking an eye, so you never know what might happen. Hopefully we won't see that, and we'll see maybe even you know, movement toward, if they get rid of the Affordable Care Act, they've got to figure out what to do about 20 million people's health care. So, you know, we might actually see a movement closer towards a single payer system and expansion of Medicaid than we have been. I don't know, you know, but we just got to keep our heads down and do the best we can. I think, you know, in past Republican administrations, funding for homelessness has actually gone up. It's been something of a fig leaf because they've cut other housing money, but they have put more money for vulnerable populations. And, you know, who knows what will happen. I mean, it could be bad, but, you know, we got to take our opportunities. I say that, you know, the best defense is a good offense. So if we have good ideas, let's go big. I mean, how about guaranteeing rent for disabled people? I don't understand why, if you get SSI and SSI can't afford rent in a single county in the United States, why should a person who becomes disabled be sentenced to a life of poverty? I think that, you know, advocating for a universal rent subsidy for anybody on SSI is an expensive but entirely justifiable policy position. How about a universal basic income? Denmark and Holland and various other countries are experimenting with that. How about just letting Medicaid or HHS or SSI pay for housing as an entitlement? I think we've got to just keep pushing things as we do it, and the fact is that we might find support in the strangest places. We might also get killed. I don't know. We'll see. You just got to keep trying. So with that, I'm going to end, and I'll turn it back over to Dottie and Brianna. I thank you for listening, and I'll take any questions.
Thank you, Ted. Thank you so much. Wow. So many ideas, and so encouraging to learn about how important good advocacy and research has been in terms of making progress in helping to expand the supportive housing infrastructure that we have in New York State. And so I just want to thank you so very much for this afternoon's presentation. And I also want to let our audience know that we've gone a little bit long on time. So we would like you to continue to send. That's okay. It was actually very compelling. And so for that reason, I want to remind our audience that we are going to continue to take questions. So please continue to send your questions in, and we plan to send them to Ted. And you can send those questions to ctac.info@nyu.edu. And we will certainly get those questions to Ted so that we can get them answered. Because it's very important for us to be having this dialogue. And so I just wanted to also take a moment to remind our audience to take a look at some of the upcoming CTAC events that we will have. And on January 5th in particular, there'll be a webinar on the need to raise the age of criminality responsibility. So we'll hope you'll join us at that time. Thank you.
All right, thank you.
Okay, Ted. Have a good afternoon. And thank you to all of our audience for joining us for this afternoon's program.